Great, thank you so much. I think I must first of all thank all the speakers and reactors and all my both my fellow moderators for having moderated this particular webinar extremely well. I think the quality of the presentations were excellent. And now we enter the open forum for discussion so that our participants of the webinar also, benefit from the open discussion which will happen right now in the next few minutes. I would request the organizers to pin up all the speakers, all the reactors, and also the panelists here so that we can open the open forum. I must once again thank Dr. Anthony Redmond, Dr. Mansoor Ali Khan, Dr. Todd Rasmussen, and also Dr. Victor for their wonderful talks, and equally informative reactions from Dr. Gabriel Salazar, Dr. John Crozier, Dr. Brian Gavitt, and Dr. Domingo Chua Jr. Thank you once again. I would just request the moderators to, if there are any questions, otherwise we would start our open discussions from some of the questions I have noted down. Are there any questions in the Q&A box or the chat? Colonel Amila, Dr. Koba, can you see some questions there for the speakers?
So one question is there to Dr. Professor Anthony Redmond. So, sir, that you have talked about Mosul response in the Iraq in 2016, if I'm correct. So, is there any positive messages, positive things we have gained analyzing the Mosul response? Where is there possibility of military units and the humanitarian units can work together with a common purpose?
Thank you. I mean, there are two elements to that. We're all trying to save lives, the military medical teams and the humanitarian teams. But as was alluded to earlier, there are difficulties for both sides if they operate entirely together and as one. In a sudden onset disaster where it is not combat related, then there are guidelines for it, and it is possible for the logistical support of the military to help humanitarian organizations. Not every organization will do that because of the principles of their organizations, but it's possible, and there are guidelines to support you in that. But once you get into a combat, then as the Johns Hopkins review showed, that once you are embedded with a military force, then you are departing from the humanitarian principles, and you may be putting both sides at increased risk. So I think it's important that humanitarian organizations and military organizations understand what it is to be a humanitarian. They can support each other's work, but in a combat, they have different roles.
Yeah, Dr. Redmond, I also had a similar sort of a question, especially because of your vast experience in humanitarian aid in various scenarios, in austere circumstances. Again, as you said, the involvement of military would make it slightly partisan, away from the values of humanitarian aid. And that's why probably both the ICRC and the other humanitarian agencies would detest from actually embedding themselves overtly into a military or siding onto the military side. What I wanted to know from you, from your experience, both you and also Dr. Salazar, is your experiences regarding in humanitarian scenarios when you were there. How much of a doubt was there on the aid providing agency itself? Dr. Salazar very well said that nowadays, even the humanitarian aid agencies like ICRC are targeted. The doctors and the ambulances and everybody is targeted because they see some sort of a partisan role of these organizations. How much was that of importance in your experience, Dr. Redmond? Sort of the sense of doubt in the areas you were serving. Actually, you were doing good work, but still there was some amount of doubt that maybe some sort of intelligence is going on, establishment intelligence is going on through you, or some other doubts. What do you think? Is it a reality, or is it just?
No, it's definitely a reality. And you have to be aware of that. And so you know what your motives are, and you may consider yourself completely impartial, independent, and neutral, but perception is the only reality. And you can very quickly and very easily either be perceived as being partial to one side, and also you may be accused for other purposes. Warring factions may not want aid to go to another side because it supports them, and so you have to be aware of it. It's always there, and it's very difficult. And there's been increasing attacks on healthcare workers, and growing all the time. I know the Red Cross has done a lot of work on it. We also, at the Humanitarian and Conflict Response Institute, are working with Johns Hopkins University on a large research project with the Red Cross, with the WHO, on research into attacks on healthcare. It is a real issue and becoming more of an issue in my experience. Over.
Yeah, I just was very inquisitive about asking both Dr. Salazar and yourself, in your experiences in working in crisis situations, did you find that even the doctors who have taken the Hippocratic Oath and to treat everybody equally, did you find that there were differences of opinion amongst the healthcare professionals themselves in order to treat a sort of a person from the opposite side, or were there conflicts among the doctors themselves mentally to whether to treat them or not? Because that's a very important issue.
Shall I go first on that?
Yeah, sure.
Yeah, I haven't come across that. I've always been very impressed because people who volunteer in a civilian capacity to go and work in such an environment, a patient is a patient, and once they are there before you, and the international humanitarian law dictates that even competence, once they are wounded and they come into a health facility, they are out of the conflict, that they are a patient. So I haven't come across that with the people that I have worked with. And equally, I've spoken with many military healthcare workers who I've always been very impressed about once a patient is a patient. And it causes many issues for them when resources are limited, and their primary deployment was to support their military unit. So these issues are not simple, but I've always been very impressed.
Dr. Salazar, your views?
Thank you. I would like to join the comments from Professor Redmond in the concept of what the ICRC, Red Crescent movement, we use as a concept of NIHA, neutral, impartial, and independent humanitarian actor, based on the Geneva Conventions. Is pretty clear that the importance of being perceived, but to prove this neutrality, impartiality, and independence. And when you're in a conflict, is the way you establish this dialogue with all the different actors of the conflict, and not be considered only for one side. That was the main dilemma during at the level of Geneva at the moment of the response in Mosul in Iraq. Exactly how to respond when there was a preconditions to be attached to the military forces to the Iraq government, and that will jeopardize definitely the concept and how you will be perceived by the other side. So that will be definitely affect the accessibility to the communities under control of the other actors. That's the pillar of the concept of the International Committee of the Red Cross in conflict situation. And how you do that is the principle of dialogue and confidentiality. Is how you work in a confidential manner. That's a very important element. The second one, as the question is concerning if doctors, medical staff medical personnel have the dilemmas to be in those contexts, and they ask the principle of neutrality and partiality, are you impartial? Yeah, now we are human beings. I mean, but it's how you maintain rationality, and emotions come at a certain moment. As one of the colleagues was saying, I was in 1993, 1994 during the genocides in Rwanda, and we used to forget there was, even before Rwanda, there was in Burundi. They were nowhere 1 million, 1.5 million. There were only 350,000 people in October 2023 when I was deployed in Kigali for the Burundi crisis. And how you to respond on all these, and how you respond in a context such as Sierra Leone and Liberia, when you have to assist people are being part of the genocide. And this is a concept of based on medical grounds. And this is the big challenge at the moment of doing triage. And as Dr. Mansour is based on medical facts. It's not according to the color of the skin. It's not according to the grade or the level of is a military, non-military, a civilian. It's based in medical elements, this decision-making process. And this is something you learn along the way, along the process. Now, lastly, is military working humanitarian? As Professor Redmond explained it properly, the dilemma in natural disasters is less difficult, definitely. But when it comes to military, it's really a challenging. We have been many contexts where we have been working shoulder to shoulder in natural disasters. Haiti, I mean, during the Banda Aceh tsunami in Indonesia, that's been examples. When it's come to military joint efforts with humanitarian actors in contexts such as in Iraq, like in Syria, like in Yemen, like Republic Democratic of Congo, these are more complex matters. So this is something that we have to be very careful. Now, there are many things we have learned from military, which is logistics, for example. The concept of deployment of medical logistics and how we develop logistics in medical settings, humanitarian context. Definitely, we have learned from militaries. And this is something that we have common. We can learn on case management, for example, in terms of trauma. I'm not a surgeon, but I heard at the moment of setting up how we exchange experience and expertise, how we introduce or we use tools developed by military medical teams in humanitarian settings in response to actors. So there are different fields of collaboration and common grounds, but when it comes to operation, it's a more sensitive matter from question of principles and the question of perception from different actors. Thank you.
Thank you. Thank you, Dr. Salazar. Any other question from any of the other speakers, Amila? Then I'll move on to the next speaker then.
Okay, sir, we can move into the next.
Okay, I have a great amount of respect for Dr. Mansoor Ali Khan, also especially because his name resembles one of our top cricketers from India, Mansoor Ali Khan Patodi. And he was a legend in his own self, and so was Mansoor Ali Khan today, as I saw him. A truly perfect presentation about field surgery in austere circumstances. Dr. Mansoor, you very well, sort of defined the role of a general surgeon, which should come back, which is gradually disappearing. Even in developing countries or so-called developing economies like India, we are moving towards more specialized care. And you very well, sort of in terms of skill sets, divided an acute care surgeon or a trauma surgeon into a trauma surgeon, military surgeon, and acute care surgeon, and also in terms of the deployment into a kinetic humanitarian and or a contingency surgeon. My question to you is, you and probably Dr. Bryan also sort of partly answered it on the in the context of the US, is the retention of skill sets. Both in military as well as in civilian surgeon population. Do you have, because I personally think that a complete surgeon, although you listed many things for a trauma general surgeon or a military general surgeon, but I personally feel if a surgeon is very well trained in two things, one is thoracic, one is vascular. These are two major things which are apart from probably the abdominal trauma, which a general surgeon generally finds himself comfortable with. Then probably he can make a good trauma surgeon also. My question was that about skills. Do you in the UK also have this kind of a thing where military surgeons go to civilian centers and civilian surgeons do have an opportunity to serve in the military flexibly, because in India, as you might be knowing, we generally live in silos, and therefore the armed forces medical service is entirely different. Although we have trainees ourselves coming to our civilian trauma center to get trained, now we have a whole MCH in trauma surgery and critical care, like thoracic surgery or like cardiac surgery. Now we have, and we've had the past experience of training at least 8 or 10 military surgeons into trauma and critical care surgery. What about the UK? And then I'll ask Dr. Brian to comment upon the US model also.
Thank you very much, Dr. Gupta, for your question. I'm going to break it down into numerous parts. First of all, you say I resemble that famous cricketer. Big difference between me and him is he was a prince. I am definitely not royalty. I'm just your average bona fide surgeon. And although he married a Bollywood actress, I would say my wife is far, far more beautiful. But we'll start off with that thing as a baseline. When you talk about, as you said, a deploying surgeon should be trained in thoracic and vascular surgery, I want to switch that around. If you think about when you go inside the chest, well, there's only 2 reasons why you're going to go inside the chest. Is either to relieve a tamponade or to cross-clamp the descending thoracic aorta. The lung parenchymal injuries are very, very straightforward to put a clamp on, staple them all. So I would actually say thoracic trauma surgery is a bit like a laparotomy, except you're going across the sternum. If you're doing a clamshell, it's very, very straightforward to manage. I would say that abdominal surgery is more difficult because there are a lot more structures in there and a lot more problems which can be managed. So abdominal surgery, I think, is absolutely key. Vascular, I think anybody who does any degree of trauma must train in vascular surgery. So abdominal and vascular surgery, if you've got a sound basis in that, you're fine. The principles of operative surgery remain the same, especially if you're dealing with trauma military surgery. If you look at the mortality within the first hour, 50% of deaths are due to hemorrhage. So if you've got somebody who can get hemorrhagic control, both in the chest and in the belly, you're actually mitigating against that risk, provided it's in the first hour. If you look at the conflicts in Afghanistan and Iraq, they actually showed if you were able to get on board the medical emergency response team helicopter with a pulse, there was a 98% chance you would survive irrespective of injury. So the key thing here is trying to get the person to definitive control quickly. And then once they're at that facility, definitive control is rapidly established. Now, the second part of your question was, in the UK, we don't have military hospitals. We have military units inside civilian hospitals. So every single military surgeon in the UK works in a civilian hospital where they will be, if not getting massive trauma exposure, they'll be getting huge amounts of emergency general surgery or acute care emergency surgery exposure. But as part of their military training, they will go and be trained on cadaveric workshops, in other workshops, on how to do military specific operating. My view on that is, once they've been given that introduction into the military operative skill set, they go back to their host hospitals and expand on it. If they're not comfortable with the neck, they attend vascular surgery lists where they're doing neck exposure. You can't turn around and say, I've got my elective practice, I've done a course, I'm going to deploy. That to me is not the way you work. You do not do your first major operation after a cadaveric workshop in a war zone. So you need buy-in from the host organizations, from the militaries, humanitarian, to actually make sure from a governance point of view, these individuals are trained to the right specification. And the middle part of your question there was when you're talking about subspecialty, I'm a firm believer in you should never force anybody to go down one route. You should evaluate them. Even with military surgeons, if they are engaged, if they show determination to expand their skill set, then they should deploy, they should be put out there. Same with humanitarian individuals. However, if you have a person in an organization who by the process of governance isn't showing that, well, I'll be honest with you, I'm a veteran now. I don't answer to anyone, so I can say what I want to, and nobody can really tell me. I think individuals who are not committed to actually gaining the skill set to be deployed shouldn't be deployed and should be given the opportunity of a one-way exit out of an organization. God, that was rather controversial, wasn't it? Hopefully that answers your question.
Well, it does partially. Dr. Brand, so you also said that in the US also you have the civil-military cooperation, very, a very well-oiled sort of a machinery there. Unfortunately, we need to learn a lot in Asia from you. Are there any recommendations of the US or the UK government on that so that we can use it and try to impress upon our armed forces medical services for, if not, sort of military surgeons actually working in civilian setups, but at least, they're rotating through high volume civilian trauma centers also, and likewise vice versa.
Yeah, absolutely. So there are a number of kind of publications that have looked at the military readiness and how to maintain readiness among surgeons in particular, and those in the what are called the critical wartime specialties. I have resources that I can forward to you on that offline. But I would say that some of it ends up being fairly intuitive. We know that, from a military standpoint, if our pilots aren't flying, they're not going to do as well. If the shooters out on the range shooting, they're not going to do their job well. And so we just kind of have to start making the case that this is that the silliness of putting a surgeon in a non-operative position and then asking them to do extraordinarily complex cases in a resource depleted or a resource poor area is going to lead to poor outcomes. And the entire purpose of having a military surgical team there is for rescue. And so I think the key with all of these things are to create platforms where people can get their reps in, where you can routinely be doing the sorts of things that you're going to do downrange. The trouble that we face in the United States, frankly, is that, a lot of our biggest and busiest trauma centers with penetrating trauma tend to be university hospital associated, which have every specialty known to man in that building that wants a piece of the action. And so, it becomes a challenge when you have a trauma surgeon who wants to be doing some vascular work, and the vascular team has vascular fellows and vascular residents who also need to be trained. And so there's the competition for a limited resource there. And so that ends up being one of the challenges, is how do you maximize the ability to expose people to something that's not in their, not typically in the scope of practice of the average trauma surgeon potentially, but definitely must be within the scope of practice of a deploying or humanitarian individual. That's a problem that we haven't perfectly sorted, but through building relationships at a lot of those centers, we've been able to maximize exposure on those sorts of things.
Thank you so much, Dr. Gavit. I have with us Dr. Raj Menon, Vice Chair of the Education Committee. Dr. Raj, any questions, comments, or reactions?
Everyone, for the wonderful talks they've all given today. As a trauma and vascular surgeon, a lot of it really resonates because vascular training is so disparate now from general surgical training, and the exposures tend to be quite disparate from the different groups of trainees in both fields. Just a question for Dr. Victoreva. In terms of general surgical residents getting vascular trained and getting some additional exposure, do you think this should be a major part of their major surgical training, or really should this be specific post-fellowship kind of exposures that they need in order to maintain some degree of currency for a general surgeon involved in military trauma or general surgical or humanitarian trauma?
Thank you very much, Raj. And so I can tell that general residents, they are taught in our academy. We have only one facility educating surgical residents and military medical students. A big military medical academy with some less advanced facilities, I would say, and to establish their circumstance, the setting where our residents, mostly general surgical residents and orthopedic surgical residents, should focus on vascular surgery, we created this platform. And we decided this to be implemented in every general surgeon who graduates from our academy. And so before graduation, being military medical student, we teach them basic level of trauma. and after graduation during general residency program, we're focusing on trauma at all. So we are not trying to press on them to become vascular surgeons. We try to organize very simple 3 days in basic procedures like vascular suturing. And at the end of the program, we'll try to organize cadaveric courses where they can learn how to do vascular exposures. And to my knowledge, as also a vascular trauma surgeon as you, that vascular exposure is the most difficult part in all this procedure, not just end-to-end anastomosis or patchplasty. Vascular exposure is what is every general surgeon is afraid of, how to expose without blood loss. And I think that the asset course is a fantastic sample of how it is organized. It is not still adopted in Russia. And we are doing the set of the courses like this, like for burn, for ultrasound, for vascular, for even for endovascular. We have a separate course, not for military surgeons, but for military, as I said, open exploration, open vascular exploration, basic procedures like suturing and temporary shunting. So every general surgical resident is learned by this technique.
Thank you very much, Dr. Riba. And perhaps just one more question for Dr. Redmond, actually. It's regarding during your deployments, whether it's in the context of war or humanitarian disease or humanitarian disaster, how much integration do you have, do you try to have with the local surgeons there and the local health facilities as compared to coming in as a parachuted in surgical force? And how important is that, especially when you're first settled down in a particular field of theatre?
Okay, we don't want to be parachuted in. We look to be invited in, and that's the strength of the WHO EMT initiative that has set up a system whereby teams can be verified, you know, what their capabilities are, and then countries can decide whether what you are offering meets their requirements. So the first thing is we're always invited in, and that may be to work in one of their facilities to support the local healthcare practitioners. But we are there as a guest. We are invited in, and we work alongside and in support of the local healthcare workers. And wherever it's appropriate, we will try and incorporate local healthcare workers within our team as well once we're there. I mean, our head of office in Yemen is a local Yemeni doctor. So it's a really good point, and it's at the heart of delivering good humanitarian care is to work alongside in your in countries as a guest. It gets more difficult in conflicts in civil wars as to who is inviting you in, who has the authority, and that's when it gets more difficult. But that's the basic principle. Thank you.
Thank you. Just for a quick follow-up, Dr. Just one last follow-up on that. When do you know the job is done, and when do you decide it's time to leave? I'm sure, of course, unless you're being told to, of course, but if not, when do you decide the mission is complete?
Difficult, but if you work with the local authorities, then you're quite right. They will let you know when your help, and much as it's appreciated, is no longer required. But the nature of the work quickly changes, and mention was made earlier by ICRC about the importance of rehabilitation, and our work changes from an acute surgical response and emergency response into a rehabilitation program. So our surgical team might be only there for a few weeks, but we've had rehabilitation teams. We work very closely with Handicap International, and working with them, we had a rehab team there in 6 months in Gaza. Following on the earthquake in Sichuan, we were asked by the Chinese government to help support spinal injury rehabilitation and work there for 2 years.
Thank you.
Thank you. Yeah, thank you, Raj. I think in the interest of time, I'll pose the last question to Dr. John Crozier. Dr. John, I would like to have your views on the civil-military cooperation and the Australian or Australasian model. Do you also have similar issues there with the military surgeons, or what sort of system do you follow?
Thank you for the question. I should from the outset say we're a country of 25 million people. We have a defence force of 35,000 full-time, so we depend heavily on reservists across a whole range of specialisations. And the complexity of the modern battle space is that those complex civilian backgrounds can't easily be matched by a full-time standing defence force of Australian size. It's particularly the case for specialist medical support, surgical support. So the bulk of our surgeons are reservists. They will upskill in a variety of the courses that we've heard about, definitive surgical trauma care asset. They're usually working out of major trauma centres within Australia. There's an obligate period of involvement with peacetime exercises before they deploy in a full-time sense. And no one goes off as a reservist. They all go as full-time, co-equal with the rest of the deploying force. We have had a significant maturation in civilian teams that are self-contained that will support a range of humanitarian type activity on request of host nations. And the last 2 decades have seen a significant maturation in that separation and the full independence, if you like, of those medical assistance teams. I would be keen to make a couple of points. Any of those deploying civilian groups should have an end state in mind before they actually go onto the ground in the host nation. It's really important that they know exactly what the preconditions for their removal or their withdrawal are going to be before they go in, because mission creep is just so easy. And we see it on both the civilian side and also on the non-government organisation side. The final point that I'll make, and this has been a common observation in a lot of deployments, I've gone in usually in a uniform capacity, but it's quite clear that a range of countries will send teams in good faith, but they're pretty ill-equipped. They depend heavily on a lot of the capability of the host nation, and they shouldn't. And similarly, they'll often turn to militaries for some of the basic logistics of repairing facilities to work out of, plumbing, getting sanitation up, and indeed food. Basic wherewithal that they should really come in with and not become an impost on either the host nation or turn to their similar nation but uniform members in the expectation that they'll bail them out. They can't, they won't, and nor frankly should they. So if I could just close with those comments, but with again extreme gratitude for the privilege of being participant in this really important activity, and it is a great privilege to hear the wisdom of the panelists. But I acknowledge there are people like Ariana Kusmanegro here tonight, wonderful leaders in Indonesia, that demonstrate so many of the lessons that have been imparted this evening.